yet to score. So we'll start the next round again to team A. So you have to identify the block structures in the following image. Important thing is you get full marks only if you identify the structure with an arrow. This one is essential to be identified. Rest of it, even if you identify, you have to identify all these three structures. Team A. Time? Time up. Question passes to team B. Time?
Cleland ligament.
Cleland. Oh, that is only one. Time up. Next, team C.
Cleland, Grayson, and natatory.
Perfect. Excellent. So this is Grayson's ligament, that is Cleland's ligament, and this is the natatory ligament, which we always forget. So that is why I asked this question. So next we go to team B now, right? In the human body, where do you find the ligament of Greppo? Time dekhna, Subhash. Time up. Pass. Ligament of Greppo. Pass.
Hand.
हैंड तो पता ही है हैंड में कहाँ पर टी में
Sir, in the hand, the vertical fibers from.
where exactly in hand
Sir, this superficial palmar arch only.
no, that is not specific enough.
In the palm region.
No, that is not specific, sorry. So none of you got it right. So basically it is in the first web space, and it is the distal commissural ligament of the thumb, which from it in the first web space. Number 1 is the ligament of Greppo. Okay. So this question was to team B. So team C, what is hypothenar hammer syndrome?
Pass, sir.
Team D.
It is basically the vascular malformation occurring in the hypothenar region due to the continuous hammering.
Be more specific. Location you are right, but you are not specific. Is it a, what kind of vascular malformation?
So it is a arteriovenous malformation it is, and it is venous.
See, it is, we have to stop this question here. We cannot pass it further because he's very close. So let's see what the answer is. Then we'll decide if we should give him or not. So it is a pseudo-aneurysm of the ulnar artery due to repeated trauma. You said you were right for this, so we can give him 5 marks, I think, instead of, this was past question. What do you think, Nikhil? Should we give him or not? Because it's a pseudo-aneurysm. He didn't. Okay, you won't get any marks, but this question won't be passed further. So this question is nullified. So team D now, last question. So this is a 26-year-old male presents with painless fusiform swelling of the PIP joint of the middle finger. X-ray is normal, but there is no tenderness or joint stiffness. What is the likely diagnosis? Time starts now. Time up. Team A.
Pachydermodactyly.
Yeah, this is pachydermodactyly. This is the answer. So after 2 rounds, what is the score?
Team A is with 15 points, Team B has 5 points, Team C has 5 points, and Team D is
yet to score. ठीक है. So now we come to round 3, and now we'll reverse the sequence of questions. We'll ask with team D. Now in this question, next question, I want exact details of the structure I am asking. Time starts now. What is this material? And I want the detail, its class and everything. Time up. Team C. Time up. Team B.
It's a 3D printed, मतलब PTFE.
No, it's not PTFE. Team A.
Peak implant.
Good. But I want full details. Peak is not enough.
Polyether ether ketone.
And which group of family it is? And what type of a polymer it is? I want full details. We can give you half marks. इनको 2.5 marks दे दो. Because the answer is polyether ether ketone. It is a semi-crystalline thermoplastic polymer belonging to polyaryl ether ketone, PAEK family. This you should know. We are very commonly using it nowadays. It is very much resistant to infections and all. So team C, your question is, identify this instrument and its use. No? Team?
Saldana retractor.
Yes,
for
and what are its
abdominoplasty.
uses?
Abdominoplasty.
Yes, full marks. This is a past question. Saldana's retractor and in abdominoplasty. Team B, identify the deformity in the following image and how it is caused.
Anti-gum deformity.
Yes, and how it is caused?
Central arch resection, sir.
ठीक है. Most commonly it is caused in malignancies, post-malignancy, but sometimes bilateral condylar injury can also cause it. So its reference has been taken from this famous cartoon. This is basically an advertisement for a cigar from where this reference was taken. And yes, of course, you've covered most of the points. So now the question is for team A, right? Identify this lesion.
Sir, malignant melanoma.
No. Question passes to team D.
Melanocytic nevus.
उसका दूसरा नाम?
Becker's melanocytic nevus.
नहीं बोल सकते उसको, correct नहीं है वो. नहीं, I want a specific name. There is a name for it. Team C. नहीं, इसमें negative नहीं. Time up.
Dysplastic nevus.
No. The correct answer is, it's a juvenile melanoma, also known as Spitz nevus. So this is a dome-like nodule which is 1 centimeter in diameter, and it occurs on face and legs of young patient. Surface is smooth and sometimes exhibits telangiectasias. Okay? So I think we are finished with this round. So what is the score after 3 rounds? Team D has yet to score. So we are now, check your buzzers now. We are going to the buzzer round, and we will have 6 questions in this round. So, but here we will have a negative marking in this. अब एक तुम buzzer वो बन जाओ. He is the buzzer judge. तुम नोट वहाँ बैठ के नोट करना कि किसने buzzer दबाया. हाँ, ठीक है. So the first question, now in this there won't be any passing, but we can ask the audience. If in case you all fail, we can ask the audience in this round. Okay? So the first question is, identify this test, and your time starts now. Team B.
ABPI, ankle breaker.
No, not ABPI, -5. Any other team? 15 seconds. Anyone from the audience? This image has been taken from Nelligan itself. So basically, चल रहा है next कैसे आएगा? This is bioimpedance measurement in lymphedema. It compares the rate of electrical transmission between lymphedematous and normal limbs. If you had noticed carefully, the patient had lymphedematous limbs on the side, they were measuring it. I'll go back to that image. Look at the image, the limb was swollen a little bit. So this is this. Next question is, identify this flap and enumerate its use. Time starts now. Time up. Anyone from the audience? Not the calcaneal तो नहीं है sir. Medial femoral condyle, vascularized free flap. So this is medial femoral periosteal bone flap, and it is used to reconstruct small bones and recalcitrant fracture non-unions. So pen drive, yes please. किसने आंसर किया था? सर ने किया, जाके दे दे सर को. बाद में लिख लो. Okay, the next question is, what is Mescalet technique of skeletal reconstruction? Team D.
Sir, it is a technique where the skeletal reconstruction is done in stages. In the first stage, bone cement is placed for the formation of a layer.
Bone cement is placed or something else is placed?
That
You have to be very specific.
allograft.
Anyone else?
PMMA, polymethyl methacrylate is placed.
Spacer.
Spacer, then biomembrane is formed, and later on,
See, it is not done initially. There is a spacer of, I'll show you the image. This is how it is done. So basically, there is a radical debridement done, and a PMMA spacer is placed, and this is covered with a free vascularized flap. And once this spacer creates a space, in a secondary stage, this is removed and bone graft can be done. I think we can give it to Team C.
Passing is not allowed.
Passing nahi hai, you can give them a pen drive. No marks, you can give them a pen drive. ठीक है. Next question. A 14-year-old boy presents with a swelling in this finger. Please suggest a possible diagnosis on the basis of this attached image. Team D.
Anchondroma.
No. Negative marking. I am going to the answer now. This is an aneurysmal bone cyst. Okay, the next question is, a 45-year-old female with a long-standing history of rheumatoid arthritis presents with the inability to extend her fingers. On examination, there is a dorsal dislocation of distal ulna. Ultrasonography reveals rupture of the extensor digitorum communis tendons of all fingers. What is the most likely diagnosis? Any team? Team A. Team A.
Sir, Von Jackson syndrome.
Yes, that is the correct answer. So what do you do in this?
Sir, we'll have to reconstruct the tendons.
Only reconstruct the tendon. What you will do with the reason which is causing it? Anyway, we'll have time to discuss about it later. I think this is question 5. This is the last question of the buzzer round. A 60-year-old woman presents with pain in the base of her thumb, worsened by pinching and gripping activities. X-ray of the hand shows joint space narrowing and osteophyte formation at the first metacarpal joint. Which classification is most commonly used to stage this condition? Any team? Time up. Anyone from the audience? I cannot give you because we had discussed this. So answer is Eaton-Littler classification. It is used for CMC joint arthritis. There are 4 grades of this classification and it depends on the joint space. So grade 1 to 4 it is graded. So with this we come to the last round and that is rapid fire round. We'll have a look at the scores now. -10. क्या कुछ confusion है? 27 and team B 15 and team C has 5. So we'll start with team 4 now. Team 4 is team D. So we'll ask you a set of questions. We'll have 45 seconds to answer these questions and you can do the scoring with this. We're starting the timer. 1 second. ये कैसे होगा? Team 4, your first question is, timer start? No negative marking. A patient develops cola-colored urine after electrical burns. The pigment responsible?
Myoglobin.
Correct answer. A 25-year-old male presents with wrist pain after a fall on the outstretched hand. Examination reveals tenderness in the anatomical snuff box. X-ray confirms a fracture of the scaphoid. What is the most common complication of this injury?
Avascular necrosis.
This is our question.
You can't answer. It is there. Yes, avascular necrosis, non-union.
No, sir, we haven't.
Achha, you answered non-union. I didn't hear it.
We have answered non.
You're wasting time. Should I go to the next question?
Take it next.
The key cytokine responsible for hypermetabolic response in burns.
TNF alpha.
Good, right answer. A 30-year-old patient presents with ulnar-sided wrist pain following a fall on the outstretched hand. Pain worsens with forearm rotation and ulnar deviation. On examination, there is tenderness between the ulnar styloid and triquetrium. Which structure is most likely injured?
FCU.
Wrong answer. Time up. The answer is TFCC. So what should we do with the third question? They have answered it. 3 out of 4, we'll give you that answer. Please don't answer in somebody else's turn. Okay?
This is for individual team.
This is for individual team. Please don't answer in between. One more question we had for you. I'll just discuss. In alkali burns, tissue damage mechanism is?
Liquefactive necrosis.
Yeah. ये आपने आंसर किया था. But you won't get any marks. Can't help it. So team 3, you gave extra time. Team 3, your questions start now. The antidote used in hydrofluoric acid burns.
Calcium gluconate.
Correct. Length gain in percentage in 45 degree with 2 Z-plasties, 2 flap Z-plasty.
50%.
Correct. A 28-year-old male presents with chronic wrist pain and stiffness. There is tenderness over the lunate and decreased grip strength. X-ray shows sclerosis and collapse of the lunate bone. What is the most likely diagnosis? You can pass if you don't know. Kinbock, correct.
Kinbox.
The topical antimicrobial agent that can cause metabolic acidosis.
Mefenide.
Correct. Next, a 35-year-old woman complains of pain on the radial side of the wrist worsened by thumb movement and gripping. On examination, time up. Sorry. Anyway,
Tenosynovium. Dequervain tenosynovium.
Is the correct, but we won't give you any marks for it. That is how it is. So how many did they get it? 4. So they got 4 correct. Now we come to team 2. And your first question is, A 30-year-old male falls on an outstretched hand and complains of pain and swelling at the base of the thumb. X-ray shows a fracture of the base of the first metacarpal extending into the carpometacarpal joint with subluxation of the metacarpal. What type of fracture it is?
Bennett's fracture.
Correct. The gold standard for assessing inhalation injury.
Fiber optic.
Correct. A rock climber presents with pain, swelling and tenderness at the proximal phalanx of the ring finger. On examination, there is a visible bowstringing of the flexor tendon when the finger is actively flexed. Which structure is most likely injured?
Pulley.
Which pulley?
A1.
Wrong answer. The first immunoglobulin to decrease after major burns. Pass. Time up. How many did they get? 2. So we come to the last team. What is the anatomical structure responsible for turkey gobbler neck deformity?
Platysma.
Correct. Sorry. That was other team. Now your time starts now. A patient presents with inability to extend the fingers at the MCP joint, but wrist extension is possible with radial deviation. Sensation is intact. Which nerve is most likely injured?
PAN.
Yes, correct. The commonest microorganism causing capsular contraction.
Pass.
In Hoffman and Kahn's classification of gynecomastia, moderate breast enlargement with minor skin redundancy in which grade?
2B.
Correct. The most reliable marker of tissue hypoxia in burns.
Lactate.
Correct. In Wong's contralateral C7, which root is time up?
Prespinal.
Sorry, which one?
Prespinal.
Be more specific. Anyway, we can't give it to you, but prevertebral root. So let's have the score at the end of this thing. In the meantime, I have an open question to everyone. We, as plastic surgeons, we always advise people to use coconut oil. So why do we do that? What is the active ingredient of coconut oil, which is the reason we advise coconut oil to be applied in all cases? There is an active ingredient. Anyone from the audience? Sorry, sir? Lauric acid. It is lauric acid. No, sir. It is lauric acid. Lauric acid is the active ingredient which gives its antimicrobial properties. So the final result is Team A is the winner with 57.5 marks. Team C is the runner-up with 45 marks. Team B is third with 35 marks. And Team D is last with 20 marks. We have prizes for everyone. As I told, 15,000, 12,000, 9,000 and 6,000. And we have so many these pen drives which are left. Unfortunately, nobody answered. We'll pass it on during the conference. Thank you. So with this, we conclude the quiz. Yes. Thank you so much.
Morning. Deeply obliged to Delhi Association of Plastic Surgeons for this invitation. My topic for today is on body contouring following massive weight loss, which is defined as loss of more than 50% of excess body weight. Back to basics, management starts with evaluation, which starts with history taking, and basically in history we are asking for the weight history, minimum, maximum and current weight, etiology of weight loss, whether it is due to diet, exercise or bariatric surgery, or more recently GLP-1 agonist. What is the target weight, current weight if it is stable, and if so, for how long? And if bariatric surgery has been done, then we are more interested in the malabsorptive types which can affect the nutritional status of the patient. Coming to the physical examination, BMI, for me, the cutoff point is 35 kg per square meters. Above this, the incidence of complication increases exponentially. But I would make an exception in cases like this with massive folds and presence of hernia, because she was unable to do any exercise due to this problem. So I went ahead and did the body contouring for her also, although the BMI was almost 40. Local examination, I cannot overemphasize the importance of proper exposure and circumferential examination. This was a patient of massive weight loss where abdominoplasty has been done elsewhere. Patient was not satisfied, and the surgeon had missed the circumferential laxity, which would be evident with proper exposure. And in sitting position, you can see the laxity has become more evident. So in fact, I planned a lower body lift for her, and surprisingly, I was able to excise the same amount of skin as the previous abdominoplasty. You can see the post-op result. And the flank also, almost 10 centimeter excision was done. And this has improved the lateral thigh. And on the back also, almost 13 centimeter of excision. So there is a lot of laxity in these patients, which is circumferential. Now, what are we looking for in local examination? Some patients with massive weight loss will have only pleats, like accordion pattern skin, as seen here on the abdomen and the lateral thigh. And if there are folds, then we look at the number and location of the folds. For instance, there can be one fold or two folds. The other fold can be higher up in the epigastric region. Or you can have three folds, the third one being the Mons fold, which is very easily missed. And sometimes you get all these folds. And these folds are due to band of adherence in the epigastric region, umbilical, and the Mons region. So you get all these four types of fold in this patient. Now the vector of fold gives a clue to the direction of laxity, like this vertical fold means vertical laxity, and the horizontal fold is horizontal laxity. And if you look at the lower back, there is oblique laxity. In the thigh, you have both actually vertical and horizontal laxity. Now, I would say translation test is very important in these patients. When we pull on the abdomen, or the patient pulls on the abdomen, you can see the improvement in the thigh. And also in the lateral thigh, you can see when the patient pulls the flank up. This signifies that there is laxity, circumferential laxity. And buttock ptosis, the signs are a short natal cleft, long buttock crease, pleats in the lower buttock, and of course you can do the translation test behind also. And this is a patient after the lower body lift. Investigation, basically we assess the nutritional status and we scan the abdomen to rule out any hernias. Now moving on to patient selection. BMI should be less than 35, no comorbid condition. Weight loss should have plateaued for 6 months, and of course patient should be in sound nutrition. So moving on to the surgery options, first I'll discuss the lower body lift. It is very effective for single folds like this. This is the early post-op, 1 month post-op, and late post, 5 years out. The result is still stable. And same patient, early post-op, and this is 5 years out. Still buttock projection and waist definition is maintained. And this is early post-op, and this is 5 years out. Again, in male patients is very effective for single lower body lift, is very effective in eliminating all these folds. And you can appreciate the improvement in the posture also. I haven't done any recti plication, but the posture improves just by tightening the skin all around. This is the side view, and this is the back view. So another patient with single fold ended up with a bad scar due to smoking, so I had to request him to stop smoking and revise the scar. And he put in his effort by doing weight training, which further amplified the outcome, which you can appreciate in the oblique view. It's a dramatic change in the chest as well as the abdomen contour. A gynecomastia correction also was done at the same time. The side view, and this is the back view. Believe it or not, this is a 23-year-old girl with massive weight loss, the massive laxity, and this is following lower body lift, oblique view, and the back view. Sometimes lower body lift is good for two folds, like in this patient. Just a lower body lift was done. I have shown you this picture before. Another patient with two folds and following only lower body lift. So massive amount of skin excision was done. Now we need different options or modifications in lower body lift because for the simple reason these patients of massive weight loss have varied presentation as seen here in the abdomen area and also in the back area. So obviously one size fits all approach will not work. So for instance, defensive lower body lift I would do in a patient with high umbilicus. Like here you can see I have drawn a defensive line below the umbilicus because I was not sure whether I'll be able to excise the umbilicus. And the old umbilicus hole was closed as a vertical scar, which is fortunately hidden in the tattoo mark. Now, what is mini lower body lift? When there is minimum infraumbilical laxity, this patient had an aggressive liposuction elsewhere and wanted improvement in the contour. So I designed a mini abdominoplasty in the front. This is a post-op. But in the flank, the laxity was more severe. So a standard flank excision was done. This is a post-op. And in the back also a standard lower body lift type of excision was done. Another postpartum patient, in the front, laxity is minimal. So a mini abdominoplasty in the front. And but laterally, if you see the laxity is severe, so a standard excision pattern. So was the case in the lower back. See the amount of buttock ptosis and a standard excision was done. Another patient with minimum laxity. So if you're doing mini abdominoplasty, you can add high def lipo also, which was done for this patient. And you can appreciate the improvement in the oblique view with some of the six packs visible. And because the flank laxity was severe, so we just did the flank plasty and a mini abdominoplasty. There is no buttock ptosis, so the scar does not have to extend to the midline. 275-degree lower body lift when the laxity is not circumferential. So in the front it is standard lower body lift. So is the case in the flank region. But in the back, the scar is stopped short of the midline. So I would call this 275-degree lower body lift. Central body lift is when the fold is higher up. So you move the excision pattern higher up, as was done in this case. So here the flank is, the laxity is quite high up. So the laxity, so the excision is also higher up. I agree the scar is high, but patient is more concerned about the fold rather than the location of the scar. This patient had an aggressive vaser lipo elsewhere and ended up with a lump of skin in the belt area. So I moved the excision pattern higher up. This is called central body lift. This is a patient post-op and oblique view. In the back, again, the fold is going obliquely upwards. So you move the excision pattern, just follow the direction of the fold. So oblique flank plasty was done in the lower back. anchor lower body lift is done when you have these epigastric laxity along with vertical laxity. This is
So you have 20 seconds left, sir.
post-op view. And another patient with anchor lower body lift. And then we have oblique flankplasty, which I have talked about. This one, an anchor lower body lift and oblique flankplasty in the back. Abdominoplasty done elsewhere, revision lower body lift with chest lift. This is the oblique view and oblique flankplasty in the lower back. Monsplasty, we have to reduce the transverse dimension.
Yep, time is up. Time's up.
Because shortage of time, Dr. Sandeep,
Yeah.
we have to be within the time. So thank you very much for the nice presentation. So we can invite a couple of questions from the audience.
Dr. Sandeep, excellent presentation.
Yeah.
Just need to just request you for the sake of the residents, when you're doing a 365 degree, what are the areas where you will not mobilize laterally in the flanks, or you mobilize the entire skin circumferentially to bring it down?
Do you mean undermining?
Undermining.
I don't undermine.
So
that
there
is
is no
one,
undermining.
One thing we should not do is undermine, because obviously it will compromise the vascularity. So we just cut down straight and just approximate the skin. No undermining at all.
Okay. And what about the ptosis of the mons pubis, which you were about to show?
Yeah, yeah.
How do you address that, especially in the males?
So monsplasty, you have to do aggressive liposuction of the mons area, and then I suspend it to the rectus fascia, and sometimes you have to reduce the transverse dimension also, and I think this is very commonly missed somehow, and patients often come for revision because of that.
Thank you.
Okay.
So thank you very much, Dr. Sandeep. Thanks a lot. May I now call upon Dr. Nitin Mokal, and he'll be talking about cleft lip rhinoplasty. Dr. Nitin doesn't need any introduction. He was in past president and renowned plastic surgeons practicing in Mumbai. Dr. Nitin Mokal.
Good morning, friends. At the outset, I would like to thank Dr. Mangal and Dr. Bhim Nanda for the invitation. The cleft nose deformity is classically present with this deformity. It also associated with the septal deformity, the anteroposterior and vertical deviation of the septum. It is very important to go ahead with the rhinoplasty only after achieving the normal maxillomandibular relationship, either with orthodontically or surgically. It's very important to do a clinical assessment in terms of a soft tissue and skeletal deficiency, and to plan the mode of exposure, probable materials used without any donor side morbility, with the aim of providing the acceptable functional and aesthetic results. I go by an open rhinoplasty approach, where the alar rim incision, the dissection is carried between the alar cartilage and the skin envelope perpendicular to each other, so it gets a good plane of dissection. Then a dissection is done in the columnar area with carefully dissecting of the anterior crura of the alar cartilages. Then in a cleft, affected alar cartilage is downward displaced. You need to release the crus. I release it like a chondromucosal release from the lateral crus of the alar cartilage and also from the upper lateral cartilage. This leaves behind a composite defect into that area. This is how you release the lateral crura of the alar cartilage like a chondromucosal flap, which brings the alar cartilage to the level of the opposite side. So this is how it leaves behind a composite defect in that area, and this brings the alar cartilage to its normal position. Then the alar web area requires a defattening and creating a tunnel till the pyriform area, which will accommodate your alar extension graft. Then the dissection is carried between the two alar cartilages to harvest the cartilage which is deformed and deviated. A good strip of a cartilage which is harvested after dissecting between the arterial crura of the alar cartilage and to the caudal border of the septum. Then this particular graft, which is a columella strut, which helps not only support the normal alar cartilage, also to the abnormal alar cartilage. It also supports the deviated nasal septum, the caudal border, and it allows the columellar lengthening. So this is how is the columellar strut which is placed in between the two crura of the alar cartilages, which provides you the good columellar lengthening as well as support to the alar cartilage. And then it is sutured with the 4 OPDS sutures to each other. Which will provide a good support to the columella. So multiple sutures have been taken. And this is how you achieve the columellar lengthening. Then we have this composite defect, so you require a skeletal support. So this can be achieved by a alar extension graft. So this is the alar extension graft which is placed. Which is stitched to the existing alar cartilage with the help of a 4 OPDS sutures. And once it is sutured, this alar cartilage which is placed into the pocket which is created after debulking that area, it just fits into the pocket very nicely to achieve the good skeletal support and alar symmetry. This is how it fits into that pocket. Then on the affected side there is a wide alar base, so that can be released by and approximated by Y to V advancement. And this is the release of the Y to V advancement. And when you redrape everything, you will find that there is always an overhang of the excess of tissue. And this overhang can be utilized as an inferiorly based alar rim flap, which is used to line the nasal lining, which is created after release of the alar cartilage. So this is how is the alar flap which is placed into the nasal cavity. This is the alar rim flap which is laterally and inferiorly based, which will go into the nasal lining. So there is no net tissue deficit in that area. So you are going to provide a good skeletal as well as a lining support in that area. That is sutured inside. So this is how is the symmetry which is achieved on table. So when the patient is in the childhood to the adulthood, in the puberty area, we are already under the orthodontic care for the alignment for the and preparation for the alveolar bone grafting. I usually prefer to do this along with the alveolar bone grafting. This is the nasal lining and oral lining. This is the bone grafting position. And this is the rhinoplasty which is done at the same sitting. And these are the patients who are in the transition of the puberty to adulthood. And you are going to give them a good symmetrical aesthetic results, pleasant results, which impact greatly onto the psychological improvement. And this is a 28-year follow-up of the patient with the same technique with only a bone grafting and rhinoplasty. 24-year follow-up with a good maintenance of the nasal condition. This is after rehabilitation. And this article is published in 2009, a simultaneous bone grafting with the nose rhinoplasty. These are some of the adult patients which are treated by the similar technique, achieving good projection, good symmetry, good alignment. You should be in position to give persistently good result with this achieving the projection and symmetry. This particular patient is operated somewhere else, wanted to have a revision. She had got the LR base area which is flattened, so I used the costochondral graft for the LR base augmentation, a columella strut and LR extension graft, a pre-fat graft for the lip augmentation, and this is the result pre-op and the post-op. This patient undergone orthognathic surgery, so post bijaw surgery and post rhinoplasty using costochondral graft and good achievement of the dental occlusion. So to conclusion, the restoring the symmetrical wing by using the composite chondromucosal advancement of the lateral crura, harvesting the septal cartilage strut for the columella as well as LR extension graft, Y to V LR cinch to narrow the wild nostril floor, incision of the overhanging LR rim skin as a flap, laterally based flap to line your mucosa, simultaneous ABG and lip nose revision in a younger age group, transition from the childhood to adulthood, minimal septal dissection does not interfere with the facial growth. And this is the chapter which I have written in this textbook. I thank Dr. Surjit and Dr. Karun for the invitation to write this chapter on the secondary rhinoplasty cleft deformity. And these are the results. The credit goes to my teachers who taught me. Thank you very much. Any questions?
Thank you, Dr. Mukul. That was an excellent presentation as usual. And now we invite questions from the audience.
Good morning. I am Dr. Rakesh Tindal. Sir, very good presentation, and I have learnt many techniques of rhinoplasty from you in past. So now my first question is, what is the earliest age at which you perform the cleft rhinoplasty?
I mentioned that I take the opportunity to do it at the time of alveolar bone grafting. If it is a severely deformed nose and I'm going to do alveolar bone grafting in a good expanded arch patient, at that time what I do is I elevate the nasal lining. When we repair the nasal lining for the alveolar bone grafting, I harvest the graft from that the palatal shelf of the which is attachment. So that graft which is deformed, I harvest it from there and I utilize it for using the rhinoplasty. So that is the time I do rhinoplasty. I prefer to do rhinoplasty.
So it means roughly at the age of 8 years.
Around 9 to 11 or so age.
9 to 11
is the time where we do alveolar bone grafting.
That's sir. Sir, one more question. Sir, for the LR cartilage augmentation, do you carve the cartilage or you have put the straight cartilage?
It is a straight cartilage. You don't require because it is a septal cartilage. You just have to put an extension on the top.
Thank you, sir.
Yeah.
Sir, one question. You said that you create a chondromucosal defect.
Yes.
So is it not possible to just dissect out the entire lower lateral cartilage on the cleft side, separate it from the nasal mucosa so that it gets separated, then advance it?
First of all, it is difficult. And the vascularity is again doubtful if you dissect it off from both skin as well as the nasal mucosa side. You require to release that because lateral crust is thickly attached to the lateral part. And you always have got the extra skin. When you redrape everything, you develop a good skeletal framework. And when you redrape your skin to the columella back, there is always an overhang. And that skin you can utilize it for lining your nasal lining.
Yeah, but there are some patients in whom that overhanging is not as much.
Yeah.
If you elevate the...
It's a good point. Sometimes when there is a LR web area, it's always a bulky area.
So probably a Z-plasty?
Can be done, but when you debulk that velar web area to accommodate your LR cartilage, then you get a good laxity of the skin that area. So sometimes you get away with Y to V advancement, the V to Y closure in that area.
I don't know, because in my cases, I always separate the lower lateral cartilage completely from the nasal lining. So I get a good elevation, then put an alar beaten graft and Z-plasty in that.
Sometimes what I do is that Technomed has given me sizes of the nasal splint. So I take a sizer measurement, and post-operatively after 1 week, I tell them to utilize that silicone nasal retainer. It helps a lot. If you use
Yes.
that silicone nasal retainer for 3 more months, it maintains the scar well because of silicone. It maintains the cavity well. The wound healing is much better. So post-op nasal splinting, yes, it helps the silicone nasal splints.
What day do you start the post-op
1 week.
nasal splint?
1 week. Because I already has got the measurement. So I tell them to buy it from Technomed to get that ordered. So in 1 week we have got a splint in our hand. So when they come for the splint removal or a suture removal, then we put the nasal splint inside.
Thank you.
Dr.
That is
Nitin,
also-
one last question.
Yes.
All these patients will have septal deviation also.
Yes.
So is there any need to put in spreader graft and osteotomy also?
That will be too radical. Too radical. We'll use reassess them later on. But doing a spreader graft and everything at the same sitting will be too radical measures to do it.
Okay, then thank you very much
Thank you,
for
sir.
the nice presentation.
Yeah.
So now can I call upon now Dr. Avishkar Mokul? And talking about pre-surgical orthopedics in cleft lip and palate. Dr. Avishkar.
Good morning, everyone. I'm Dr. Avishkar. I'm an orthodontist and I specialize in cleft lip and palate rehabilitation completely. So I'm here to talk about slideshow. Yeah. So I'm here to talk about pre-surgical orthopedics. It's a textbook in itself. So let's try to finish this in 15 minutes. Right from the Greek history to Webster's dictionary, orthopedics has a lot of definitions. With respect to cleft lip and palate, let us stick to we straight, we correct, and we try to mold the alveolus to get ease of surgery and to get predictable results for our patients. So the chronology is for every cleft lip and palate procedure that we do some amount of pre-surgical orthopedics, then we do the surgical procedure, then we evaluate the results, and then we decide upon the next steps. So whenever a patient of cleft lip and palate comes to you, this is the kind of work pattern that you should ideally follow. You first do the nasoalveolar molding in the first 2 months, then you do the lip repair in the 3 to 4 months, then the palate repair. Then from 6 years of age onwards, you have the major step of interceptive orthodontics and orthopedics, which is technically preparation for the secondary alveolar bone grafting, which you may do between the ages of 9 and 12. Then post that is puberty, where you start with comprehensive orthodontics and some amount of orthopedics to either prepare the patient for orthognathic surgery. Then once all the growth is completed, you do the lip nose revision, the rhinoplasties, and if required VPI correction. And the final step is the prosthetic rehabilitation of the smile design. So just to outline, the major orthopedic steps are the nasoalveolar molding before the lip repair, the interceptive orthodontics before bone grafting, and the comprehensive orthodontics before orthognathic surgery. So first we do the nasoalveolar molding. So technically you're using an acrylic plate with a nasal stent for basic approximation of the nose, the lips, and the cleft alveolus. Your orthodontist can use any kind of appliance of his choice, either an active one to expand and approximate the alveolus, or a passive one where he is just approximating the alveolus. There are a lot of techniques by Grayson. There's a modified Grayson technique as well. According to the new technologies, we have 3D nasoalveolar molding techniques and 3D printed nasal stents as well. There are certain cases where the alveolus is okay and you just need some amount of soft tissue approximation where you can do only lip taping or you can use a Dynacleft. So like I said, NAM reduces the severity of the defect, so it is just easier for the surgeon to do the corrections. You get some amount of better nasal symmetry, ease of surgery, ease of feeding, and better nose premaxilla and arch development as the child grows. Now there are a lot of debate about NAM. Let's discuss it sometime later. So NAM is done, lip repair is done, palate repair is done. Now the child is 6 years of age. Now you begin with interceptive orthodontics. So the interceptive phase generally has a maxillary arch expansion phase. every patient with a cleft lip and palate, most of them will require arch expansion. So you either do a slow or a rapid expansion. And cases where you see some amount of maxillary retrognathia, you can either do maxillary protraction using a face mask or bone anchored maxillary protraction. So let's come to arch expansion. So basically you expand the arch to gain arch length. You create space for dental alignment. You create sufficient space to coordinate your maxillary and mandibular arches. And most importantly, you create space for bone grafting. So if age and time permits, you start with slow expansion with some amount of appliances like the jack screw or the quad helix, or the current favorite ones is the Invisalign palatal expander. Or at times, if time is less and you require immediate results, you do ahead with rapid palatal expansion like we did in this bilateral case. So we achieve this kind of expansion within 15 to 20 days. Then we lock the plate and we consolidate for 3 months. Post 3 months, we remove the plate and the patient can go ahead for bone grafting. In bilateral cases, we do one at a time. We do the right first or any of the sides first, wait for 6 months and do the other side first. Post the bone grafting, we start with orthodontics, comprehensive orthodontics. And in this particular patient also, you see the kind of arch development that we have. You see a 3-piece maxilla nicely consolidating into one piece with the canines erupting as well. And most importantly, the frivolous premaxilla slowly gets sufficient amount of space to integrate into the posterior maxilla. The second type of orthopedic procedures that you can do is maxillary protraction. So the basic funda with which you do maxillary protraction is you have to do first maxillary arch expansion. Then for the same appliance, we have hooks on which we can apply the maxillary protraction face mask. Now these kind of procedures are generally done for borderline cases or for minimal class 3 cases where maxilla needs to be advanced by few millimeters. So by doing this, we get a good positive overjet, we reduce the traumatic bite, and we get a good template on which soft tissue healing and growth can occur. Now in the current times, because the kids are not ready to wear this protraction face masks altogether, there are situations where we put BAMP plates, so bone anchored maxillary protraction plates. So these are just plates that we put with hooks in the maxillary posterior region and mandibular anterior regions, and you can run class 3 elastics on them. So it gives you the same effect which is done after maxillary expansion. So bone grafting is done. Now the child has reached puberty. So for every cleft lip and palate patient, you can have 3 scenarios in front of you. Let us discuss scenario 1. In scenario 1, the maxilla and mandible are growing together in sync. So technically, you do not plan on doing any kind of orthognathic surgeries for them. You do good amount of orthodontics. Now, every orthodontic patient has 2 kind of results that you get. First is 70% of dentoskeletal changes and 30% of orthopedic changes. So in this patient also, you see the left crossbite has been corrected just by braces. No expander was used. So you align everything, you create space for the prosthetics. If required, the patient undergoes nose revision, and in the end, you do the prosthetic and the smile design. Now coming to the interesting scenario, which is scenario 2. So in this particular scenario, you have maxillary deficiency while the mandible is normal. Now you can have maxillary deficiencies of 2 types. You can have the maxilla en masse deficient. So if it is deficient within the ranges of 6 to 10 millimeters, you can do one-shot orthognathic surgery for advancement. If it is beyond 10 to 15 millimeters, you will have to do distraction osteogenesis. The second type of maxillary deficiency is only anterior maxilla, where you will have to do anterior maxillary distraction. So when you are in a situation where you have to do orthognathic surgeries, you might have to undertake any kind of protocols. Basically, there are 3. First is the post decompensation surgery, where a lot of orthodontics and arch preparation is done. Second is the very popular one nowadays is the surgery first, where the surgeon directly does the surgery. Orthodontics is done later, and a surgery early protocol. Any protocol you choose, you have to make sure that the arches are aligned and coordinated. You have sufficient space to move the jaws around to get the desired clinical results. Adequate understanding of the post-surgical post-surgical occlusion is important, because you do not want patients who cannot close their mouths after surgery, and all this can be achieved by accurate planning. So this is a patient where we planned on doing post decompensation protocol for a class 3 patient, in which we were planning to advance the maxilla. You see the kind of malocclusion that she had. So we had to do orthodontics, get everything in line, get some amount of symmetry. So when we decided on the surgery, we took the intraoral scans, which is the STL file. We took 3D CT scans, which is the DICOM file, 1 millimeter slice thickness with soft tissues. And then you get this kind of a profile in the surgical planning softwares such as NemoSafe, NemoSurge, or of Materialize Mimics. On those particular softwares, we plan the surgery, we check the soft tissue profiles, we see the final occlusion, we make the 3D splints, we assess the post-op occlusion that we get, and then we go ahead with the surgery. So this is the kind of occlusion that we achieve. More or less 5 to 6 months after the orthognathic surgery, Mokal surgeon really likes to take the rhinoplasty. So we follow this particular protocol. So we do pre-surgical orthodontics, align the arches, do the surgeries. 6 months after after orthognathic surgery, we do the rhinoplasty, and 3 months after the rhinoplasty, we do the smile design. This is another patient treated following the same protocol. I am showing repeated patients because protocol needs to be reproducible for getting consistent results. Now the second scenario of maxillary deficiency is you just have an anterior maxillary deficiency. It's not an en masse. So if your maxilla is small, ideal treatment is to enlarge it, not to just protract it. So you have to consider anterior maxillary distractions in maxillary retrognathia more than 6 millimeters. You see the red lines, the posterior teeth are in correct occlusion, whereas the anterior teeth are in retrognathia. So you consider such patients for anterior maxillary distractions. Other indications for AMD is patients having velopharyngeal insufficiency. So the patients, cleft lip and palate patients already have a space between the soft palate and the posterior pharyngeal fold. So if you end up advancing the maxilla en masse, you increase that particular space. More air goes into the nose and the speech worsens. So in such patients, anterior maxillary distraction is a good idea. Secondly, in cleft patients, you have very small arches. The size of the teeth is big. Number of teeth is at times also bigger. So rather than extracting teeth randomly and aligning arches, it is better to rather enlarge the size of the arch via distraction and then perform orthodontics. Other cases where we do AMD is where there is no good bone for rigid fixation. So rather than that, you grow bone and let it stabilize. We generally use a Hyrax based anterior maxillary distractor. We consider cases for AMD only after all the permanent teeth have erupted. It just gives you good clearance for your osteotomy cuts. If pre-surgical orthodontics is possible, you should do it because it gives you good symmetry, so your results are predictable. If it is not possible, then yeah, you have to take the risk and leave the rest to your orthodontist. So you clinically evaluate the patient, we do the Ceph analysis, like I said, we do the surgical evaluation as well. We see the soft tissue profiles. We like to place the distractor before we take the patient on table. So all the surgical cuts, the horizontal cut from the piriform aperture 2 to 3 millimeters below the infraorbital foramen, vertical cut between the second premolar and the molar, and the palatal osteotomy cut Mokal sir does using a curved palatal osteotomy. And you need to check whether the entire system, anterior maxilla, has been osteotomized. So once the osteotomy is done, we wait for 5 to 6 days for the soft callus formation. We generally start with distraction on day 7 with 1 millimeter per day protocol. And these are the kind of results that you see immediately post distraction. All the photos have been taken on the day of locking of the distractors. We take CBCTs every 3 months and 6 months to see the kind of bone that is formed. You see the immediate change in the base of the nose, the position of the upper lip. So in teens, you can do post-surgical orthodontics and get a very good occlusion after distraction. These are some photos where we are doing the orthodontics with the distractor in place, and in some photos without the distractor in place. Now AMD in adults also has a wonderful protocol where you can do some amount of orthodontics for say 2 to 3 months, get some amount of alignment, then do AMD. Now we consolidate the AMD for minimum 4 to 6 months, then utilize this 4 to 6 months for post AMD orthodontics, get some symmetry, do the rhinoplasty with the AMD distractor in place, consolidate more for 3 months, then do the prosthetic build-up after 3 months. So within 1.5 years, you have very good results. See, this is 1.5 years. Similar patient, 3 months of pre-surgical orthodontics, AMD.
Sir, you have 30 seconds left.
Alright, so the last scenario is bijaw surgery, where good amount of pre-surgical orthodontics is required. We do the surgical planning in the same fashion. Splint 1 is intermediate position with maxillary advancement. Splint 2 is mandibular setback. We get everything is decided pre-surgically, the kind of results that we are required to get, and these are the results that we generate.
Time up.
A bit was remaining, but I thank you for the opportunity.
Thank you, Dr. Avishkar. Any questions from the audience? So, just a small query. In a government setup where the maybe orthodontist is not available and the NAM facility is not available, so what do you suggest should be done for the clefts? What is the minimum that can be done to maintain some kind of, get symmetry?
Ma'am, lip taping. That's
Lip
the
taping
bare
is the
minimum that we can do. Because even if you're not putting force on the alveolus and you're putting force just on the lips, the force that is transmitted to the alveolus, at least some amount of approximation you will get. You require a dedicated orthodontist for NAM. So if the is not available, then at least basic taping should help. Some help should have.
And
for the
also, do
surgery.
you think that since now more and more of surgeons are doing the Bardak's technique, the alveolar arch deformities are less compared to the VWK which was being performed earlier?
No, ma'am.
So-
I have yet not have had that many cases to compare both the results. But because we have a steady protocol which we follow, so irrespective of the kind of arch that we get, we do expand, we do align, and only the cases where I have had to expand less, I have had better results. In
Okay.
cases where I have had to expand a lot for whatever reason, let it be the scarring or the surgical technique, results have been a bit dicey.
And if there is a palatal fistula, what do you advise? To do the fistula closure first or to do the arch expansion first and then do the fistula closure?
No, ma'am. I would advise to do the arch expansion first because that is also a deformity. Unfortunately, they are interrelated. So, preferably, we expand first, get the arch form as ideal as possible, as functional as possible. Then you have a true fistula in front of you. Like in this case, you don't see the fistula, but there is a fistula between the arches. So the moment you expand, you see the true size of the fistula. Depending upon the true size, you can decide which kind of fistula closure do you want to do. Will you require a standard closure or a tongue flap or a buccal flap or any kind of thing? So this becomes much more better.
Dr. Avishkar,
So-
last question. So in all cases, once you have nasal alveolar molding, cleft lip repair, you're doing lip with anterior repair or not? No, so you have a protocol of doing lip along with the anterior repair in the first stage?
So to tell you the truth, we don't do NAM.
You don't do that.
Yes.
Now, after the lip and anterior repair, if there is a disparity in the arch, means misalignment of the arch, you need to do an alignment of the arch, and there is, especially in bilateral cleft lip and palate, where the lip is protruding, premaxilla is protruding. So
Yes,
you
sir.
go for the orthopedic appliances before the palate repair.
No, sir. We do.
So that's what I've seen some of your patients, because unless you do arch expansion or bring the premaxilla in alignment, it becomes extremely difficult to repair the anterior palate, and then you leave behind the fistula anterior, which becomes extremely difficult to repair.
Yes, sir.
So what
Yes,
we
sir.
do, we want to align the arch before we take up the patient for the cleft palate
Yes,
repair,
sir.
because
Yes,
unless you
sir.
leave behind the palatal fistula.
Correct, sir. So the latest consensus, which I was not able to talk about, was that INAM is compulsory in wide bilateral cleft cases where you have to make space for the premaxilla.
True.
At times you can let it be for unilateral cases or normal cases. Wide bilateral cases have to do NAM.
Because if the premaxilla is anterior,
Yes.
it's very difficult to repair.
Yes, sir. So this is what you get.
Yeah. Thank you very much. Thanks
you,
a
sir.
lot.
Thank you. Thank you for the opportunity.
So can I call upon now Nitin Mokal, Dr. Nitin Mokal, and he'll be talking about distraction osteogenesis for facial skeletal deformities.
Distraction osteogenesis is the biological process of gradually controlled displacement of the surgically created fractures that are gradually separated by incremental traction, which results in simultaneous expansion of soft tissue and bone volume. The Snyder in 1973 distracted canine mandible using an external distractor. Micheli and Mayotte distracted canine mandible with intraoral distraction device. Karp in 1990, who did a biopsies at multiple times And he created 4 stages: stage of fibrous tissue, stage of extending bone formation, bone remolding, and mature bone formation. Joseph McCarthy in 1989 did a first case of a unilateral craniofacial disc microsomia, and Ortiz Monasterio and Fernando Molina in 1990 in Mexico. There are so many multiple distractors are progressed over the period of time. In a craniofacial part, you can do an anterior cranial distraction and a posterior cranial distraction. The indications for the posterior vault distraction is the syndromic pansutural synostosis with raised intracranial tension, Chiari malformations with cerebral herniation, and cervical syringomyelia. We do a posterior vault distraction technique where we do a lateral coronal osteotomy, downward slope occipital bone osteotomy, and inferior to the inion and torcula. These are the osteotomy lines. And this is a patient who has a severe craze ICT with copper beaten appearance. In a prone position, we do a posterior coronal flap. Then the periosteum is elevated along the craniotomy line. It is sufficient enough only to accommodate the distractor and to do the osteotomy. The craniotomy is marked and the placement of the distractor, symmetrical placement of distractor is marked. This is a temporoparietal craniotomy which is done by my neurosurgery colleagues. Then the horizontal occipital osteotomy is done till the midline. The midline part is done with the help of a forward and backward cutting craniotomes, bone cutting instruments to prevent damage to the midline sinus. Then the distractor is placed and the activating screw is brought out of the one of the flap. So that is the activating screw which is brought out. And the distractor is placed in front of the craniotomy line with the help of plates and screws. This is how the distractor which is placed across the osteotomy line. All the screws are 4 mm in length, self-drilling screws. This distractor is of a KLS Martin distractor. It has got the 2 hooks which rest onto the craniotomy line. This is how you fix all the screws. Then the distraction, whether your osteotomy is complete and your entire segments are moving properly or not, are activated on table. The activator in clockwise direction which is used, and you can see that gradually with the rotation the distraction started on table. This test is very important to confirm that your craniotomy line and osteotomy line is quite complete. You can see that the distraction occurring on table. So this confirmation of distraction is very, very important. And this is how is the bilaterally symmetrical distractor is placed and the suture is closed with the activator coming in front. The activation started on the 5th post-op day, the 3 turns in a day that will distract 1 mm a day. And this is how you find that the distraction is achieved. Maximum distraction possible with the distraction is 2.5 centimeter. And at the 3 months of duration, you remove the distraction, you can find that a good bone has been formed. And this is the result after 6 months post distraction. And you can see that the good expansion of the cranial skeleton, which will relieve the patient from the raised ICT. Advantage of the posterior wall distraction is that you do only the cut onto the craniotomy, no dissection involved in the dura, no dissection involved on the subperiosteal region. The only disadvantage is that if there is apparatus failure or there is a CSF leak due to the abutting on the dura, and it requires a general anesthesia for the removal. Then comes the distraction of the midface and the cranium. The commonest indications are courrosons and apperts, with the severe midface hypoplasia with upper airway obstruction, raised intraorbital tension, raised intracranial tension. There are 2 types of osteotomy, the Lafort 3 with supraorbital extension of the distraction if the brain and cranium is normal, and the monoblock frontoorbital Lafort 3 osteotomy with the distraction in which there is a raised ICT with a cranial deformity. I use this internal distractor which has got the zygomatic foot plates and the temporal foot plates. 3D models are used to pre-operative planning about the placement of the distraction foot plates and their contouring and their cutting. All the assemblies are autoclaved individually. This is a patient late presentation of corrosions with raised intracranial tension, raised intraorbital tension, class 3 malocclusion causing obstruction sleep apnea. We did a craniofacial approach by frontal craniotomy, periorbital osteotomy, zygomatic arch osteotomy, the lateral wall of the orbit coming down till the pterygomaxillary disjunction. Then this is a stereolithographic model. Then this is the osteotomy which is completed both at the skull base and the lateral part. The multiple craniotomies are done for the posterior decompression. This is the osteotomy which is confirming that your entire Lafort 3 element, orbitomaxillary element is free, so that the placement is easy. Then the galioperitoneal flap is lined to do the skull base area, which will prevent the CSF leak, because your craniotomy line goes along the roof of the orbit into the frontonasal area. So this area need to be covered nicely with the galioperitoneal flap, and it is, you keep it slightly loose, because as your entire element is going to distract forward, so this flap should not get pulled out. Then the frontal craniotomy segment is sutured, fixed back to the supraorbital bar, so that the entire orbital and maxillary and frontal element becomes one unit, and the bilaterally symmetrically placement of the distractor is placed. And again the activation is done on table to confirm that your assembly is moving fine along with the, as a monoblock, the both maxilla, orbit and forehead moving together. Then on 5th postoperative day, we teach the parents to how to move the activator, so that 2 turns in the 1 turn in the morning, 1 in the evening, which is done by the parents. And this is how you achieve the distraction, both the forehead and the maxilla. You can see that the maxilla is advanced very well forward. The orbital proptosis is gone. The profile has changed. And this is an 8-year follow-up with good. And this is another effort with very severe fronto monoblock advancement with 7-year follow-up. With, you can see that the lateral profile showing a good advancement of the maxilla in front of the mandibular arch, as well as disappearance of the proptosis. So advantage of the internal device is a better patient compliance, unidirectional single vector. Disadvantage is unilateral vector and needs removal at the time of the removal of the distractor. If your requirement is more, that is in such a patient where it is a tracheostomy dependent corrosion, severely hypoplastic maxilla and cranial deformities, no way you can put in an internal distractor. So in that case we use the pull technique, where you use a rigid external distractor. The operative procedures remain the same, the galioperitoneal flap, and then the distractor vectors are placed on the mounted on the plate. So both the two plates are placed into the zygomatic area, and the wire passed under the plate and the bone, and which is brought out through the skin into the zygomatic area. So this is the one vector which is going through the zygomatic bone. So that will pull the orbits. This is on the opposite side, the same vector on the opposite side. So this is the first vector which comes from the zygomatic area. Then you replace your frontal craniotomy segment, fix it with the plates and screws, and then this is another vector which is in the frontal area, which is supraorbital area. So in this particular patients we have used the 2 vectors. If you have got a very severe form of the class 3 malocclusion requiring a good pull, then you can add another vector through the pyriform area. You take an intraoral incision, place 2 plates as pass a wire through the bone as well as through the plate for the additional anchoring. The same time you do a posterior decompression and then you suture it back. So you have got these 2 vector, lower vector through the zygoma, upper vector through the frontoorbital bar, and this is the external device, you can place it. And these are the activation screws and the plate. And then you can start distracting on a 5th postoperative day. The advantage of rigid fixation is that you can change your vector. If you find on an X-ray that, and even clinically, that your maxilla is moving in a different direction in an anterior open bite, then you can change your lower vectors and you bring the maxilla down in a different direction. And this is how you change the vector. And as soon as you distract on almost 10 millimeters, you can, patient is weaned off the tracheostomy because your maxilla has come forward. And you can find that there is marked improvement into the airway. And this is how the achievement of the airway, and this is almost 4-year follow-up showing a good correction of the orbital proptosis. And this is a 4-year follow-up showing the good cranial remodeling has been done. But because of his class 3 malocclusion and there is no control on his lower jaw, he is going into the maxillary mandibular prognathism. So this patient do require orthodontic alignment, and he may require orthognathic surgery in near future. But primarily now he is off tracheostomy, he is raised ICT is released and everything. And this particular patient, agonal cruisons, we use 3 vectors, and this is a post-op result. You can see that the lateral view showing a good maintenance of the occlusion and the profile, and the correction of the proptosis. This is a 20-year follow-up of the same patient. The advantage vector, this is the mandibular distraction, where we used the internal mandible for the placement, and this is the placement of the distractor. This is the osteotomy which is done after placement, and this is the distractor on place, and then this is at the time of removal showing a good bony formation, and this is the result.
Sir,
Another patient with 20-year follow-up.
time's up, sir.
So take home message is, you require proper planning, neurosurgery, orthodontic colleagues, use of 3D models, selection of the distraction apparatus, overcorrection and maintenance, and follow-up for the relapse. Thank you very much.
Thank you, Dr. Nitil. Very complex distraction. So what is the cost of distractor?
Cost is, for the red device, it comes around 5 lakhs. But the advantage of red device is that you can use it multiple times.
Okay.
So
It
cost
can
is
be used
only for
again.
the anchoring plates and screws.
All right.
So
All right.
you see one good TPA patient or a company patient, you buy one from them, and
It
then
can be
the
used
rest
again.
you utilize for the other poor patients.
So we can have a couple of questions from the audience. So if there are none, thank you very much again. So I'll call upon Dr. Mohit Sharma now. So he'll be talking about comprehensive management of facial palsy and overview. Dr. Mohit. Dr. Mohit is shifted to close to in NCR, is a renowned plastic surgeon practicing in